Today on Townhall.
Look at ambient listening. Really cool technology. You don't invest in really cool just for really cool sake. You invest in what is the ROI and what problems is it solving for your organization, and is it aligned with the mission?
My name is Bill Russell. I'm a former CIO for a 16 hospital system and creator of This Week Health, where we are dedicated to transforming healthcare one connection at a time. Our Town Hall show is designed to bring insights from practitioners and leaders on the front lines of healthcare. All right, let's jump right into today's episode.
Welcome to one more episode of This Week Health. My name is Nayan Patel. I'm the CIO at Upson Regional Medical Center. In today's town hall, I am honored to be joined by Joe Longo, who's the Senior Vice President and Chief Digital Information Officer at Parkland Health in Dallas, Texas. Welcome to the show.
Thank you, Nine. How are you?
Doing great. Thank you for taking the time to meet with us today. We're going to cover a lot of different things, but today we want to really look at one of the busiest hospitals in the nation. It's quite unique to the challenges that you have under Parkland. And so would love to start with you giving an introduction of yourself, your background, a little bit about your role within the organization.
Sure. First, thank you for having me. Like you said, my name is Joe Longo. I'm the Chief Digital and Information Officer at Parkland Health. Parkland Health is one of the larger public health providers in the nation. We're in Dallas, Texas. For those who aren't familiar with Parkland Health, in the 50s, so this is where they brought Kennedy. And we built a new hospital in 2015. In August of 2015, we populated it. We have the busiest single location ED in the nation. We're level 1 trauma, level 1 burn. We have 96 individual neonatal ICUs. We birth anywhere from 12 to 14,000 babies per year. Safe to say we're a pretty busy place. As a county teaching and safety net, it's a pretty important place here for the Metroplex. It creates challenges, but also a very fulfilling place to work. We're very mission driven here at Parkland. I do have a couple of stats for you, Nayan. We have about 1.1 to 1.4 million outpatient visits per year. We do about, in a day, about 31 to 32,000 lab tests are performed. We do about 1,400 radiology exams in a day. About 71 babies are birthed. We have about 560 patients seen through our busiest single location ED in the nation. So a lot going on at Parkland. A lot of focus on the services that we provide here in the DFW area. We do serve the underserved. Typically, we do see anybody, obviously, who gets hurt in the 250-mile radius of Parkland from a trauma perspective or a burn perspective is going to come to us no matter who you are. But then we also serve the underserved of the community, those with high barriers to care, whether it's social determinants of health or other barriers. Those are the folks that are the people that we are serving at Parkland Health, and I'm happy to do it.
Oh, that's great. Thank you. That's awesome. I appreciate all that information. One of the things is I actually have a personal connection with Parkland too, because
Oh, yeah?
my mother-in-law worked for 29 years in your level 1 trauma center in the burn center. And apparently everything she said is you do some incredible work there, including having a nationally recognized NICU. So in this community, it is a vital piece of this community. Let's jump right in then. We're going to cover a lot of different topics today. But one of the key ones that I want to talk about is leadership, what you've done, where you've taken and progressed this organization. You've been with Parkland, I believe, 8-9 years or so now, and you've been pivotal in overseeing all of Parkland's IT operations, driving a lot of the digital innovation. Tell us a little bit about the unique challenges that you have of being a public health system and balancing that with the community needs of the organization. I'd love to see how you navigate around that a little bit.
Sure. No, great questions. I'm a boomerang here at Parkland. So I've worked here, left and came right back after a short stint on the West Coast. So I came back in 2012. So that's already over 12, almost 15 years ago. And when I came back, I was over all the technology going into at then being built, one of the largest hospital projects being built in the globe at the time. And that was really cool. We had to do a lot of anticipating what 3 years in the future, what those standards for technology would be. And we had a few home runs and a few things that are underutilized to what I originally envisioned would be utilized. But very proud of our home runs. And I'll give you a few examples. We were going from a 1 million square foot campus, again, 1954 built building, same building where they brought Kennedy. We were in that building for about 69 years or so. And we were developing what's now well over 4 million square feet of pure clinical space, 17 floors, a couple of helipads, like I said, 96 individual neonatal ICUs, very big ED, 40 some odd OR, and some of the floors are over 2 football fields long. The scale of this building was just tremendous. So when we were trying to solve for future problems, going from 1 million to 4+ million square feet, we were moving from a centralized nursing model to a decentralized nursing model. We said, what are the technologies that were going to solve the problems of that future? One of the things we saw was the need for mobile devices. And again, in 2012, not the norm. People were dabbling with iPhones and other Android devices. They were just in its infancy of secure text. But we really doubled down that said, if we're going to have nurses and care teams spread out that far, where it's not as reasonable to have a central location where you're running multiple football fields back and forth each day being that far, we moved to a decentralized nursing model where alert alarm aggregation and secure text was going to be the foundation. So we doubled down on that. We went live with a company called Extension Engage, which was then bought by Boycera, which now, here many years later, is a standard of care. If you're not using that type of technology, you're probably behind. Another one was VDI. Back in 2012, VDI was out there, but not in healthcare, and definitely not at the scale that we were looking at. And we looked at each other when we were saying, okay, how are we going to move? Again, busiest single location ED in the nation, multiple babies being birthed, NICU. We had a pretty large psych and psych ED population. This is not a place that we can shut down and move everything from one side of the street to the other. We had a 1,000-foot bridge made as part of this, connecting the old campus to the new campus. But it still wasn't feasible to move all of the endpoints and equipment from the old to the new while still caring for the patients during. You can imagine for all the tech folks out there, it's not as easy as just picking up a computer and moving it. You've got to remap printers, label printers, scanners, peripherals, all that fun stuff. So we really looked at VDI, which was being used in other industries, pretty prevalent, but not in healthcare. And we took a gamble. We had to retool our staff, get them used to VDI to not only build it, but support it. And we leveraged some Imprivata tap and go while we did it. So there could be tap in, tap out, and roaming sessions, which ended up being a wild success. And with what's in it for me, for clinicians. But again, it was a gamble. It was new. It was a pretty nascent world, but we did it and it was a wild success. When we have some more time and maybe over a beer, we can talk about the ones that weren't home runs and weren't wild successes that became standards of care a couple of years down the line. But I think what I'm trying to say is there's been a lot of opportunity here at Parkland Health to help folks that are typically not enriched with digital or technology capabilities. And we're able to do it at a scale that then others in the medical community can say, oh, it works there at Parkland. Let's apply this to our facility, to our patient population. And we've seen a lot of things become quickly, very quickly, go from being prevalent in other industries, but not healthcare, and then leap into healthcare and then become standards shortly thereafter. And that's what I really look forward to, is always finding what's that next big leap that we can invest in from a digital or technology capability and then share with the medical community, because that's part of our mission, and get it out there and enhance everybody's ability to care for their patients.
Yeah, and I think one of the things that you just mentioned is about standards and making it more streamlined. You, like you said, you're in a public health system, so your ability to set, I want to say, guidelines of an alternative way, because some organizations have a ton of money and they're going to be looking at future things as well. Your organization is going to operate differently. The people within your organization are also going to operate differently. So can you share me some thoughts? Maybe it's your leadership principles on how do you develop your team and keeping them motivated as you're trying to make all of these changes?
We call that building the airplane while it's in flight, right? You can't stop
Yes.
operations and stop everything that the organization does so we can rally the troops and figure out how we're going to rebuild something. That's never an option for any of us. So I like that question. For me, I'm very blessed. When I took over as the CIO, and now I'm the Chief Digital and Information Officer, it was about 6.5 years ago. I had a lot of very talented folks working on my teams, like many of you probably do. And I said, what's the value I can add? What's the differentiator we can make working in the challenging environment that we are, but also in a very mission driven environment that's very fulfilling? Just so happens on my desk, I've got a placard that we have in all of our conference rooms and most of our desks. And it has the Parkland mission, overall mission, which is advance wellness, relieve suffering, and develop and educate. And then I created an information technologies purpose. Why do we exist? Is it to connect computers and fix your mice? No, we have two quotes here. It's we care for the people who care for our patients, and we strive to be an extended member of the care teams. We put that right on the placard. I start a lot of my meetings with reminding folks of that because our talented folks can do their craft virtually anywhere. We got a lot of options, right? If you're a network engineer and you've got certain certifications, you can work virtually in any industry. And mechanically, you may do very similar things. But when you work at Parkland and you get that call in the middle of the night that a switch is down, that could mean that there's 42 devices in the busiest single location ED in the nation that are down. And those caregivers may not be able to keep up with the volume using their typical methods of connecting to the systems and the equipment that's used to being in one of the most connected physical spaces in healthcare. When you start thinking that way and you start drawing that alignment to what we actually do here above and beyond what your mechanical day-to-day job is, that means something different. When you're trying to make this place a fulfilling place to work, it's not just, and it's not knocking if you work at an Amazon distribution center or somewhere else, but you could do that same job anywhere. Working at Parkland, it means a little more, and it has, in some cases, not to be over dramatic, could have a life or death implications on what you do, which makes it very important.
It does, absolutely. And I think anyone who is in the hospital or healthcare environment, we're in a servanthood environment for sure. So you have to have a different mindset. One of the things you said was really interesting because it's remind me of a quote that one of our materials management folks said many years ago that I was working with. And because he said, we're in the business of saving lives. That's our
Mhm.
business. And in the end, no matter what role you have within the organization, his role, he says, we take care of people who take care of people. At the end of the day,
Well,
that's exactly what you said.
I
And so,
probably stole it from whoever said that.
yeah, so that is the purpose, right? We're taking care of people who ultimately are taking care of the actual patients. And I think having that kind of purpose and mission for an IT or IS department, that has value and it keeps those people motivated.
And you said something right there is value. And that's something we've focused a lot on because our jobs are changing and our jobs are changing fast. And whether you're a CIO, CDIO, or whatever variation of CIO you are, or you're an analyst, individual contributor in the IT team, your job isn't the same as it was 5, 6, 7 years ago. And I can almost guarantee 3 to 5 years from now, your job's not going to be the same. The advent of cloud, with the advent of AI, the advent of a lot of technologies and capabilities that create these tectonic shifts in our industry, there's going to be some skill sets that get devalued that used to be really important a few years back. And there's going to be some skill sets that are getting valued. And that's what we're working a lot on is what is our value today? What's our value going to be to the organization 1, 2, 3 years from now? Now let's get into the specifics. What are the roles that we have today under IT? And how do we get them synergize those roles and responsibilities, synergized with that value of the near future? And what is the skills gap? So if we're devaluing maintaining servers and we're valuing moving to cloud, we're valuing vendor management skill sets, we're valuing customer relationship management, which sometimes is a very uncomfortable spot for classic techies, right? We're valuing connecting value of the how to use the technology to the workflow. So you have to get closer to what the business values and how we add those capabilities into their workflows. Another big one that I've been beating my drum on is OCM, organizational change management. When I look at the biggest challenges we've had in the recent past, big projects that were a lot harder than I think they should have been, the root cause mostly points to we could have done a better job to change the hearts and minds of folks or do better, more effective change management, explaining the why, getting the education, getting the right stakeholders. So those are some of the things we've been looking at to say, what is that value of the near future? What's the roles and responsibilities that are going to be aligned and creating that value? What's the gap between what they can do really well now and what those skill sets are going to be here in the near future? Let's boil that frog one degree at a time rather than rip that rug out from under people at the last minute. Let's say, here's where we're going. And we're going to throw out a lot of cliches out there. So let's throw out the Wayne Gretzky skate to where the puck's going to be
Right.
cliche. But if we know where the puck's going to be and you got to be there, what skill sets that you don't have today will you need in that near future? And let's work together to fulfill those gaps. So that's a lot of what we've been working on more recently, to your point of how do you align with the mission? How do you create a purpose? And then how do you evolve with that purpose?
That's awesome. And many of the successes you've had at Parkland, we're going through this digital revolution, but you've already gotten a lot of these successes, I'll say check mark, but you had to work hard to get there. You've got the Chime Digital Health Most Wired recognition. That in itself is a proof of what kind of leadership you have. You've got the high trust certification. You've got HIMSS Analytics Stage 7. From a maturity model, that's not easy to achieve, right? Especially in a public healthcare system.
Yeah.
There are things that you set, like where that puck is going, right? What you want, because these different models that are out there and your ability to achieve them is what's driving you to go where you go next. But as you're starting to think about innovation and all these new things that come into play, we get exposed to a different shiny widget every day, right? I know you get calls just like I do probably of, here, we've got something to talk about. What is it? So how do you evaluate or prioritize some of these new technologies in a complex environment like Parkland? What are your thoughts around that?
Great question. I steal a lot from my peers. I find a tremendous value talking with you, talking with a lot of my peers out there, because the fact is, yeah, we've achieved a lot at Parkland, but we've got a lot of opportunity from a technology perspective. And just because we achieved something a few years back, we've seen cycles happen where we backslid in maturity in some areas and we have to regain that. So that's a really awesome part of our job because it's so dynamic that if you're high achieving now and you stay status quo, in a year, you could be way behind if you haven't made up that ground because that's how fast things are moving. So Parkland, we have peaks where we're doing really well. We have valleys where we have lots of opportunity to be better. I work with my peers, I work with my network to say, I do this pretty darn good. I might be biased, but we do this pretty good. Let's share. I do really poorly, or I have a lot of opportunity in another area. I hear you do that really well. So that was one of the things about 2 years ago that we had a lot of opportunity was how do we deal with this increased demand for more and more technology capabilities and the digital transformation that everybody was echoing out there. That digital transformation started many years before people started using that terminology. So the demand was through the roof. We were getting 150 to 180 demands for major IT projects per year.
It sounds about right.
It's a lot. And we did not have the capacity to do that. And we tried. And we were a little bit tribal a few years back on how we approached it. It was not FIFO. It wasn't first in, first out. It wasn't LIFO, last in, first out. It was LIFO, loudest in, first out. So,
Yeah, that's the squeaky wheel mentality is
Right.
something that certainly exists for a long time.
Right.
But how do you end up saying, or how do you tell the business a little bit? Is it starting to get easier to say, not necessarily say no, but no, not right now. We got
Yeah,
all
it's-
these other things to work on, right?
It's not easier, but we've leveraged some processes that I learned from some of my peers in the healthcare space where they really did a great job of strategic portfolio management from the ingestion of demands. We use ServiceNow as a platform. So we do the ingestion into ServiceNow. We run a digital health governance where we evaluate the business cases of those. We have some prioritization from a multidisciplinary group as part of that governance. We put together a roadmap. We revamp that roadmap. We leverage capacity planning also in ServiceNow, where we have all of the different resource pools and what our capacity versus what the demand is going to gobble up in those prioritized fashions. And I have an artifact at any given time that shows the next 2.5 years of where our resources, where our IT investment is going for net new stuff. It could be a request, something smaller than a bread box. It's still new stuff, as we call it. Or it could be big stuff or stuff that is project level. All those projects go through our DHG process, which is ostensibly a strategic portfolio management process. And is it perfect? No, far from perfect. But is it a lot more structured than it was 2 years ago? Absolutely. Is it Joe in his ivory tower deciding, oh, I like that, or I like that, or no, it's a lot less of that and more democratized, but strategic. So we know what our enterprise strategic goals are. We know where some of the investments are going to be better suited and have better outcomes that are Parkland specific. Again, it may work really well at your organization, but if you don't have the volume or you don't have the patient community with the same challenges to access the care that I have, the technology solution, although it may be cool and great, may not have the same ROI here at Parkland. So we evaluate all of that and we try to make the best decisions with the information we've got. So that's how we figure it out. We're getting better at saying no. So if you're at the bottom of that list, and here's where it's challenging, and I think everybody can probably empathize with this, is we're not saying that your idea is a bad idea.
Absolutely.
There are a few bad ideas. Let's not kid ourselves. But the vast majority of the ideas are great ideas. But when we evaluate it and you can't do everything right now, the things that bubble to the bottom, it's just more humane sometimes to say, we're going to reject these rather than we're going to always push them to the bottom. So it's going to be 2.5 years from now, and then 2.5 years up, it's back to the bottom. It's going to be another 2.5 years. You build resentment, you build discomfort, you build distrust in the process. So we're just getting used to saying, okay, the bottom X% that we can't get to within a reasonable amount of time, a year and a half, we're going to reject for now and then have them reassess. So is it a perfect process? Absolutely not. Is it still hard to say no? Absolutely, because you get into that inevitable conversation of, but it's a good idea. Not saying it's not a good idea, just saying it's not above the line as if we were doing a budget process for that same year.
No, you bring up a really good point, because I think all of the requests any of the hospitals are getting from an IS perspective, it is business driven, but really what it comes down to is how do you quantify the good idea into something more tangible? And we can do the business analysis to do ROI and see the budget impact. But a lot of times it comes down to, is this a nice to have, need to do, or wheels fall off type of thing, right?
Absolutely.
And the nice to haves, you really have to ask, is it really just a nice to have, or is it a need to do? You want to be able to do the medium and highs because that's all your capacity is going to be able to do.
We talked about this earlier. Is it a nice to have versus is it going to be standard here in 1 to 2 years? We have this conversation more recently around ambient listening. Everybody's talked about ambient listening. AI in general is on this super hype. So people tend to abandon discipline and basic decision making, which again, our process kind of forces that a little bit more, but the emotion of the hype kind of gets in the way. But you look at ambient listening. Really cool technology. You don't invest in really cool just for really cool sake. You invest in what is the ROI and what problems is it solving for your organization, and is it aligned with the mission? Is it going to have this wild financial ROI? It may, but it may not. However, what you got to evaluate is for ambient listening specifically, you're raising that cognitive burden of the or already overburdened clinicians, specifically the providers. Are they going to be easier to attract and retain? Are they going to be more engaged because you're giving them a technology capability which lifts that overall burden? And most importantly, in my opinion, is it going to be standard within a year or two for all organizations that if you fall behind the curve as a CIO, CDIO, all of a sudden you just created an environment where you've got a leg down compared to your peers on attracting and retaining provider talent. Those are the things that are the other end of the equation, not just financial ROI. Totally agree with you.
That's a great point, because what you're really showing is, as an organization, we have to be able to provide those technological advances to our providers who ultimately are providing the care. And they're not going to come to our organization if we don't have what in their mind is minimum standards, because of this is where we're at. It's just 20 years ago, not necessarily everybody was on an EHR. And those who got there quicker were able to get things done in a different way, more efficiently, and provide ultimately better quality of care.
But that wasn't universally understood 20 years ago. You had a lot of narratives out there saying EHRs aren't going to stay, EHRs complicate my life. But you're right. It became a standard very quickly that if you listen to a lot of the loud narratives out there, you would have found yourself behind. You have to be able to cut through the noise and really look at it in a disciplined, pragmatic way, and sometimes be lucky and guess right. Totally
Yeah.
agree.
In speaking around technology and budgets, because ultimately I see ourselves as we're just CFOs of technology at the end of the day. We're going to try to implement things with the amount of dollars we have. So your organization, although it's a safety net hospital, I think we've seen it triple in terms of budget in about 10 years. So that's pretty huge as a safety net hospital. So maybe you can discuss the challenges you've had of the organization over the last 10 years, growing in scale, and all the different things that you've had to change, and some and not so much around financials and scale and governance.
We run into financial constraints as much, if not more, than your average non-public provider. But we've had a lot of great support from leadership and buy-in that an investment in technology capabilities can amplify in other clinical or operational ways. And we've proven that more times than not. That has resulted over the last 10 years, seeing a pretty big increase in IT spend. I will tell you, we don't have the luxury of a lot of failing fast. There's not a lot of innovation gambles we can take because there's not that bucket of money that you can set aside for just taking wild swings to see we'll get knocked out of the park. So we do have a requirement to lower the risk a bit and really invest in the high likelihood that we're going to have the returns and be aligned with the mission and add value to the organization, whether it's higher efficiency from a operational or clinical operational perspective, whether it's lowering the barriers for patients to get access to lower acute care and avoid having folks have worse outcomes and have to come in through our ED. That's the lens that we look at it through. And if we can prove that the value is there and the ROI, again, not just financial ROI, but overall system ROI, we've had that trust from our chiefs, we've had that trust from our board, and we've proven it pretty consistently. So that has presented itself in that increase in budget, as well as obviously increase in spend around the necessary cybersecurity. I wouldn't say that we have this abundance of money being thrown at us, but there's definitely a responsible increase of investment in digital and technology at Parkland. And we know that every dollar that's coming to us is a dollar not going to, let's say, subsidizing certain care and certain procedures. So we better make sure that dollar is going to equate to more efficiencies and the ability to reach more patients and hopefully work upstream and make sure that we're keeping them healthy and out of our acute care facility. That's one of the things that's really cool at Parkland is that, lack of a better term, perverse incentive to drive people to higher acuity services is not there at Parkland. We're incentivized to keep people healthy and away from our higher acuity because you can do a Google search and see what our payer mix is and see that we're probably not getting reimbursement that fully covers the costs of those higher acute services. Therefore, we're incentivized to keep people healthy, which is good, better for them anyway, and keep people out of our acute care facilities and the higher cost procedures. We're really freed to think innovatively, to say, what can we do and where can we focus strategically to work upstream and keep people healthy and hopefully out of the acute care. So we do a lot in population health. We've stood up some really cool digital health center here in the last couple of years where we're really focused on delivering high efficiency, low cost care to, one, identify at-risk patient populations and intervene where they are, intervene to make sure that they don't fall through the cracks and become a higher acute patient coming in through our ED. How do we get to them upstream, keep them healthy, keep them compliant with lower acuity procedures, lower acuity contacts, and hopefully keep the population more healthy.
Yeah,
So
no, this is all about focusing on patient outcomes and improving quality of care of patients. It's technology can do a lot of different things. And in the public health sector, I think it's amazing what you all have been able to achieve. And you touched upon something earlier. We talked about ambient listening, and not so much as do we not, it's going to become a standard. It's going to be something that the providers are going to expect when they come in X years, whether it's 2, 3 or 4 years. It's going to be pretty much prevalent everywhere. Virtual nursing is another one, right? Just the concept of virtual nursing, it's really not to replace, it's just to augment and taking off all of those extra mundane tasks that the current physical nurses have to deal with. And have you all looked into even something like virtual nursing, and where are you at with that? I'd be curious to see what that is, because it really is an augment to
yeah,
day-to-day operations.
you hit the nail on the head. We've looked at a few things where I guess we would call ourselves close followers. We're trying not to be too bleeding edge and take too many risks, like I said earlier, but where there's good synergies with what would make good ROI for Parkland specific patients, Parkland specific services. Virtual nursing is something that we're pursuing to supplement and be more efficient with the high volume of care that we provide. I mentioned it just a few moments ago, our digital health center, it's not a call center that delivers telehealth. It's like some people think it sounds like. It's truly leveraging data, leveraging analytics, working within the Epic system to look at work queues of folks that are high risk of falling through the cracks and having worse outcomes, and then having efficient and effective methods to outreach to those folks to make sure they're on the right path to staying healthy before they fall through the cracks. And that's a pretty strategic capability we put in place the last 2 years that has a lot of ability to grow in more and more use cases. Same vein, like you said, in virtual nursing, I think I'm pretty bullish on that, and having some ability to add value specifically in the Parkland ecosystem. Same thing, we were pretty early adopters of hospital at home. Again, we're perpetually full as an inpatient. We've got a massive hospital. And again, most of our admissions are coming through our emergency department, and it's the busiest one. What are the types of things that can decompress? And hospital at home was another thing during the pandemic that came up, and we've been leveraging with a fair amount of success to decompress the lower acuity admitted patients and making sure that they're in a space that can be more conducive to their situation.
All right, so one more topic before we try to close it out with some professional insights. But cybersecurity, I think that's something that's becoming critical in healthcare, with just trying to protect and safeguard all of our patient data. It's a complex environment. You have so many interfaces, so many vendors to deal with. Third-party risks are all over the place, right? Can you tell us a little bit about what Parkland has done to keeping sure where your compliance is where it needs to be from a cybersecurity standard, but also what do you do for best practices in educating your staff?
Yep. So I got to always be careful, like we all do. Don't want to telegraph too much that would put us at risk, because we never want to be at risk. But we've
Absolutely.
a lot of investment over the years in cybersecurity, not only the tools, but the services, the education, and gotten a tremendous amount of support from our leadership and our board, because you can't read an article without seeing major impacts due to either ransomware or other security events. And we're at high risk. Again, we are a safety net, a teaching facility, a really integral part of caring for the most vulnerable here in the DFW area. So if we found ourselves in a situation where we're severely hindered of being able to provide that, the whole region would feel the pain. So we're very sensitive to that. Yep, we are, and I won't tell you the specifics, but we are always investing in the most modern, most capable tools. We're always investing in the most capable people and services to make sure that we have the redundancy and the coverage, because the tools are just the tools. Who's acting upon those tools? So that's another thing. We do a lot of our tabletop exercises to make sure, okay, if we are without our main systems, how do we operate? It's going to stink, but how do we ready ourselves to make it stink less? I know that's real technical terms, but that's the name of the game is let's not be caught by surprise. And you said it just a few minutes ago. Third party risk. We've been talking about third party risk for years now. Oh my God, third party risk. Are you doing everything to mitigate your third party risk? This year was a tough one. Two big ones were actually third party risk realized, and most of us felt that pain. So that wake up call from warning over the last many years of, oh, we need to be ready for third party risk to actually realizing it, it really hits home of what the impacts are. But more importantly, it actually reinforces, I'm going to look at this silver lining, how we did respond when the third party risk did hit. Could we have been better? Could we have been worse? In my opinion, it could have been a lot worse. I've seen people around us that were in a lot worse situation, but there's always opportunity to be better. So it's preparing folks, getting over the initial shock of how awful it could be, and then start working on, okay, we're in the disaster. How do we solve the problems? I am tremendously blessed that Parkland is a disaster center and people band together when the worst cases and worst disasters happen. Parkland's the place where the people band together and get stuff done in the most critical timing. I am very lucky to have that capability, that culture, that people capabilities behind me from that aspect. I would rather not deal with it at all, but inevitably, if you have to deal with it, it's these folks that we work with. It's really nice to have by your side.
Yeah, and you're in a facility that handles a lot of trauma, right? So from a disaster standpoint, there comes a lot of unknowns that happen every day, right? So your organization definitely has to be able to uniquely shift as needed for the type of care that's needed at any given time. And it's all back about service to the community. So who would have thought your role would have been where you are now? I mean, I can only imagine a little bit of how your role has evolved over the years. So maybe you can tell us a little bit about how you got to where you are, like what inspired you to pursue a career in healthcare IT. Share a little bit about how you got to where you are.
Great question. I think most folks that were in this role, 10 plus years ago, probably went the traditional route of a highly technical, either network or infrastructure, mainframe, and then maybe outsource services into a role like this. I started my career more on the software side. I then got a little bit of alignment early on in my career in the Midwest with a small EHR that started growing. You all probably are familiar with them. Learned a lot, got a lot of exposure to a lot of different health systems across the country, evangelizing EHRs. Did some consulting, did some work on the vendor side, went back to consulting, came to the provider side. And once I was in the provider side, like I am here at Parkland, I really found the home. I really found a place where I felt like I can add the most value and do the most good. And I pride myself on really leveraging other people's expertise and knowing how to hopefully integrate and align folks to row in the same direction, because there's a lot of talented people we all have on our teams, much smarter people than ourselves. And if the value that you bring to the table that I know I brought to the table was how do we speak the multiple languages from ITEs to clinician to operations and try to align to make sure we're all adding the most value. That's what I saw my job as, that I found some success with.
We're definitely facilitators of technology and experience, right? Because as you're saying, you don't have to know everything. And there's so many other organizations that are doing what we do, but we have to ask a lot of questions to help us get where we want to go.
And our roles, our job is to not only do what we do really well today with small incremental process improvements and gains, but we've got to, again, we're going to throw a lot of cliches out there, back to the Gretzky cliche of skating where the puck's going to be. We have to anticipate where that puck is going to be. We have to anticipate what does 1, 2, 3 years look like, what's 5 years look like. And if our folks are surprised at major erratic pivots, that means we're not doing our jobs. If our folks are feeling unprepared or feel like the rug's pulled out from under them, that means we didn't anticipate accurately enough or proactively enough to say, this is where you're going. Let's start skilling you up over time to be of value here in the near or long future. If you don't have that influence to get people to wrap their heads around, but this is my identity, this is what I'm good at, and realize that If that gets devalued enough, that's an identity hit. So there's some influence there. There's some trust that needs to be built. Our currency as CDIOs, CIOs is credibility, and we
But
strive for value. We have to deliver value, and our currency is credibility. So if you can't maintain and manage that, it makes our jobs a lot harder. What do you think about that topic, Nayan?
no,
Do
I think one of the things you just mentioned is influencer, right? So I think the term CIO could actually be chief influencing or
I love it.
influencer officer, because that is a big part of our role as leaders,
Mm,
is mapping and with the technology capabilities, because technology hasn't been the biggest issue. It's implementing and getting the user
right.
adoption of where it needs to be and sustainable, right? And then, as you said, figuring where the puck is going next, right? Because it's going to constantly change, it's ever evolving. And so, how we are looking to move to the next puck and balancing the budget along the way, right? And being able to keep what we have in place sustainable, because that's a big thing. And you have to retrospectively look back on things,
Mhm.
because we implement some things and a couple of years from now, it may not be effectively used. So we really need to come back and say, can we cut the cord on this, right? We push back a little bit, because while it may have been valued in the beginning, if it's not sustainable, it needs to be cut. So it's an ever evolving effort, but it's your ability to influence those leaders, the operational leader, whichever service line you're talking to, and whatever technology they want. No, I think it's great.
100%. And cliche alert number what, 6? No one to hold them, no one to fold them. We get so emotionally attached to the investments and the projects we make. It's so hard to cut those cords sometimes, but that is that level of discipline to know it's no longer adding the value it originally was, maybe the first few years you were running it, or even tougher decision is, hey, we put a strategic business case together. We're doing a project. We have high hopes for it, but it's just not producing. Do we fold it right there? Do we cut the cord? It's such a tough, emotionally charged decision to make, but you have to be able to do it, to your point.
Let's wrap it up here. Is there anything else you'd like to share with our audience about your vision, or any insights you have that you would like to share?
Nothing that I don't think we've touched. You've been a phenomenal interviewer slash facilitator. You really pulled out a lot of great topics. So thank you for the opportunity to have this conversation with you.
Yeah, no, I really appreciate you and Mara, all the work that you've been able to achieve, the passion you have within the organization to make it grow the way you have. Just excited and happy to have you as part of our tech community. Yeah, thank you. Take care, and have a great week, my friend.
Thank you, sir. Take care.
All right.
Thanks for listening to this week's Town Hall. A big thanks to our hosts and content creators. We really couldn't do it without them. We hope that you're going to share this podcast with a peer or a friend. It's a great chance to discuss and even establish a mentoring relationship along the way. One way you can support the show is to subscribe and leave us a rating. That would be really appreciated. Check them out at thisweekhealth.com/partners. Thanks for listening. That's all for now.